I come to the first talk on overview and workup of Phakic IOL. Thank you. I don't have any financial interest in any of the products shown in this. Phakic IOL is an intraocular lens which is placed inside the eye in front of patient's natural lens to correct the refractive error. And these are available in three types as per their presence of the site at which they are placed. It could be angle supported when they are placed in the angle of the anterior chamber. It could be iris fixed, maybe anterior or maybe anterior to the iris, phakic IOL, and another the posterior chamber phakic IOLs, which are very popular now. And I will be, or our course is focused on this kind of lenses only. There is a long history. There has been long thirst for the correcting the refractive error in a permanent way since 1953, when Strampelli and Barreker and many others came out with many lens design at various places in the eye. But because of the poor quality of imaging and poor understanding of the eye and its structure and the poor quality of lenses available, we could not do it. These are the iris fixed very size lens, which was at one time they were very popular, and we have also done. This is our case which we did earlier, and it has shown a disenclavation, means one haptic has been dislodged, and this has it came out in very inflexible model also. Then in year 2006 or so, Akrishov came out with the Cachet phakic lens, which was anterior chamber foldable lens. But all these things didn't work because of the complications related to the cornea, to the iris, to the uveitis, development of glaucoma, and retinal pathologies. The one which is now most popular and most prominent and most sought out and most widely practiced is the posterior chamber phakic IOL, which we are going to share now. And this is the model or the first prototype which was developed in 1986 by Fedorov. He designs the first posterior chamber phakic IOL from silicon in the collar button shape or a mushroom shape. So this, but it lost its glory at that time because of the reasons, various reasons. And now it has come up, and ICL or the Star company is the one who has done a lot of research on this and who has worked very hard and come out with various shapes, models, and now the present one is widely acceptable all over the world. The advantages of posterior chamber phakic lens is it stays behind the iris, it is far from the endothelium, there is excellent cosmesis, invisible to the eye, it remains close to the nodal point of the eye, and there is a gain in retinal size image as compared to other available phakic lenses, and there is greater effective optical zone because it is close to the nodal point and it is as compared to the corneal plane. So we get a greater effective optical zone. So the chances of glare, halo, and other issues are minimized or very, very less in this particular type of posterior chamber phakic lens. Then sulcus located IOLs, it's a stable location, allows for toric design with same platform, that there is a less chance of rotation of the lens, and easily removable or exchangeable. Various videos we will be showing here when we require to exchange or the lenses or expand the lenses, how easily they can be done. And there is no fixations into the tissues unlike other lenses because of the lens material type. It doesn't, there is minimal fibrosis or hardly any or no fibrosis at all, and does not alter the shape or remove the tissue unlike the corneal based procedures which permanently decreases the thickness of the cornea. So the present one, which is the ICL or implantable collamer lens, is made up of collamer material. There is a central vault. As you can see, there is an anterior curvature which is present in the central part of the lens, and peripherally they are at a different plane. So there is a central vault, central elevation. and this makes the IOL, keeps the IOL away from the lens. This comes in a foldable variation, so a model, so we can implant it with a small incision surgery. It absorbs ultraviolet radiation, but the important thing which is here is the sizing issue. So in each eye, the size has to be measured and each lens has to be ordered according to the patient's eye, and it comes in various sizing available to us, and we can fix a particular size of the lens in particular eye, in that particular eye. Advantages of IOL is that the material is very biocompatible. Collamer attracts a layer of fibronectin. As you can see, there are in the middle, in the right picture, there is a layer of fibronectin. So, and this is a collamer material. So it repels all the proteins. That's why the fibronectin inhibits the deposition of other proteins, and the proteins are not deposited. Thus, collamer lens is not recognized as a foreign body. As compared to silicon, which shows a lot of proteins deposited over it on the bottom picture on the right side, collamer lens there is hardly any protein. So the quality of vision is very good, and there are no deposits on the lens. So the patient enjoys a very good quality of vision. And other important thing is that there is a maximum light transmission. And there is because of this collamer material, it doesn't produce any reaction in the eye. So the important part is that molecular size of the collamer material is 100 nanometer, so shorter than wavelength of the light. That's why the light can pass through it very easily, and there is a maximum light transmission, better optical performance, excellent transmittance and low reflectance pattern. It is very flexible, and there is a less glare in halo, or rather I should say no glare in halo in all these cases. We have done in uniocular eyes also. When there is a uniocular eye myopia, patient doesn't find any problem with the natural eye or natural crystalline lens and the unoperated eye and between the two eyes when we have done it in one eye as well. It is available in a spherical power of 0.5 diopter to -18 diopters, and in toric variants of +0.5 to +6 diopters. So we can correct up to +6 diopters of cylindrical power. Similarly, in hyperopic model, it comes from 0.5 to 10 diopter, and with 6 diopters of correction in hyperopic lenses also. So it comes in steps of 0.25 from 0.5 diopters to up to 0.3 diopters, and thereafter in a 0.5 diopters increment from -3 to 18 diopters. It is available in various sizes of 11.6, 12.1, 12.6 and 13.2 in a very large eye. So the design is that with the new lens model, which we are using frequently now in all our cases, it has a central opening, which is called as a centroflow, which is available in this. This has a diameter of central opening has a diameter of 360 micron in size, and it is designed to restore more natural aqueous flow and eliminates the need for iridotomies. So with this, there is an equilibrium is maintained between the aqueous behind the lens in the posterior chamber and in front of the lens. So through the center of this, the aqueous keeps on flowing. Otherwise, in previous models, the aqueous could not pass through the center of the lens, or they have to they move around the lens, and which is the part which is covered by the iris. So there was no free flow of aqueous from the posterior chamber to in front of the iris in the anterior chamber. So that was the issue. So that's why we had to do YAP peripheral iridotomies. With this particular lens, with central flow design, it doesn't require any opening. And there are two openings on the either side and around the optic, and this facilitates it provides redundancy for the central optic port in case the central optic ports get occluded. So there is a chance of fluid can go through it, and it helps in removal of the viscoelastic also during the procedure. So this is the greatest advantage of it. We don't require any viscoelastic material. The newer BHASIN ICL has got a larger optic zone. So that is from 5 millimeter, now it has increased to 6.1 millimeter in a low power range. And above this, above 14.5 diopter, the central optic zone is 5.51 millimeter. So this is another good advantage of this. Coming to the workup, we have to plan it in case where the myopia or the refractive error is stabilized, which is at the age of 21 years. Maybe after 18 years we can do, and up to 45 years. But there is no age barrier. Stable refraction should be there. It is more common in cases of LASIK rejects due to high myopia or thin cornea. We will continue it for another 2 minutes. Thank you. Thin corneas of less than 500 microns. And in cases of dry eye where we cannot do the LASIK procedure, we should avoid doing LASIK procedures. And large pupils, excessively flat or steep cornea, we can think of these Phakic lenses. When there is no previous ophthalmic surgery history, should be done, and no, which is a relative this thing, and no previous ocular pathology like cataract, glaucoma, uveitis, keratoconus, Fuchs dystrophy, or any other corneal pathology should be there. A complete ophthalmological assessment is done, uncorrected visual acuity, best corrected under manifest and cycloplegic refraction, complete slit lamp examination, assessment of cornea and lens. There should not be any corneal pathology or vascularization or lens pathology, cataract or etc. IOP there should not be glaucoma. Angle should remain open 3 to 4. Corneal topography and keratometry is done in all the cases, and to rule out any subtle changes or early form of rustic keratoconus, etc. Endothelial cell count should be more than 2000, and fundus examination, especially peripheral retina. The two most important things which has to be taken into consideration is the anterior chamber depth, which should be more than or equal to 2.80 millimeter, excluding the corneal thickness. This is internal corneal depth. And another important thing which has to be done, especially for these cases, is to measure the horizontal white-to-white distance. Coming to the anterior chamber depth, we measure the internal anterior chamber depth, which should be more than or equal to 2.8 millimeter, and this is what is recommended. And this is excluding the thickness of the cornea. And we measure white-to-white by a simple caliper, as you can see on the top right side, and we can mark it. And before using this caliper, we should measure it on the ruler, steel ruler, which is also sterilized. But nowadays we use the digital caliper, which is the best way to measure the white-to-white. And apart from digital calipers, we can measure white-to-white. We can get some idea by OpScan, Pentacam, IOL Master, UBM, Vernier caliper, and some other autorefractometers which are available with you. So white-to-white measurement should be done under the microscope in high resolution. In a supine position, patient should be in a lying down position, and it is measured from middle of the limbus to the middle of the limbus on the other side. And we treat the surface with anesthetic drop and calibrate the caliper before use. As you can see here, there is a small video how we use it, and this is a digital caliper. We measure it from the middle of the limbus on either side, and this here it shows 11.16 millimeter. So this is very simple, but it has to be done in a sterile environment. Coming to the sizing, accurate white-to-white measurement is why it is very important, because if you have not measured the white-to-white, this is the ICL where we can see, and this is the natural crystalline length. The space in red mark in between two, which is measured, is the vault, which we call, and this is the distance between the posterior anterior lens surface and the posterior surface of the ICL. So this ideal size of the vault is 0.25 to 0.75 millimeter. And this on slit lamp we can compare with the corneal thickness. Average corneal thickness, if we consider, is 500 micron. So our vault should be half of the corneal thickness, or 0.25 micron, or 1.5 times of the corneal thickness, that is 750 micron. Beyond this or less than this, the lens or less than half a millimeter of the corneal, the vault, it is dangerous. And undersized ICL with less fault will increase the risk of anterior subcapsular cataract, and oversized ICL will raise the intraocular pressure because it is going to push the iris forward and close the angles. So the next comes after doing all this preliminary workup, then we order place an order and send all these measurements to the company. Company sends us this sheet wherein it comes the spherical power. We tell them the cylindrical power, axis of the cylinder, keratometry measurement, anterior chamber depth from the internal side, corneal thickness, white to white measurement, and corneal lens sphere, and any previous intervention if it is done. So they come up with this report, and they come up with the model, what to lens type, like in this particular case, a 12.1 millimeter size lens with plus 14.5 diopters and plus 1.5 diopters correcting at 100-degree toric ICL is suggested. And then it is going to tell us also about the residual expected refractive error, which is very minimal in this, and the lens model serial number is saved for you. If you place the order, then they will send us the material and lens to us, and when the lens is available with us, we can plan out the surgery. Thank you.